Hi, my name is Gopi Nayak. I'm going to be going over head and neck spaces. So the goals of this talk are to understand the spatial relationships between the spaces of the neck, to learn anatomic boundaries of the different spaces of the neck, with particular attention to the interfaces with the skull base, and then lastly to familiarize yourself with the contents of each space to help guide your differential diagnosis. So to start off with, we're going to divide the neck into suprahyoid and infrahyoid compartments based on our little horseshoe-shaped hyoid bone, which we can see here on the sagittal image, located sort of at the base of the tongue and about halfway up the neck on our coronal image. So the spaces of the neck are divided into their respective compartments based on these different fascial layers. I'm not going to spend too much time on the specific layers of fascia, but it's important to know that there are 3 layers of deep cervical fascia, the superficial layer, the middle layer, and the deep layer, which are outlined in these different colors here. And I'm going to be going back to this diagram several times. So these are the spaces that we're going to cover, and you can see that there are a couple of spaces that span both the suprahyoid and the infrahyoid neck. So this is just a corresponding CT image at the level of the nasopharynx. It goes along with this diagram, and this is the scout view that just shows you which level we're at. Same thing with the coronal image. You see the intracranial compartment here, the skull base, and then we have the mandibular ramus here. So same thing with the suprahyoid neck. This is the corresponding coronal image. We have the intracranial compartment, the skull base, and then the mandibular ramus. And then in the infrahyoid neck, here's our corresponding image, and you can see here on our scout image, we're well below the level of the hyoid bone here. So we're going to start with the parapharyngeal space, which is a very centrally located space in the neck. It's drawn here in yellow. So the parapharyngeal space is going to abut the skull base superiorly. Inferiorly, it continues down to the level of the hyoid bone, and it's going to be continuous with the posterior submandibular space. Laterally, we have the parotid space, medially, the pharyngeal mucosal space, and then anteriorly and laterally this larger masticator space, and then posteriorly we have the carotid space. So the parapharyngeal space is mainly a fat-containing space, and so on our axial images here we see sort of this centrally located low fat density area, and slightly lower down at the level of the oropharynx, here's our fat-filled parapharyngeal space on either side. And on this coronal MRI image, you see this nice bright T1 hyperintense fat stripe extending from the skull base down to the level of the submandibular glands. So besides fat, we also have minor salivary glands as well as some coursing vessels in the parapharyngeal space. So for a lesion to be primarily arising from the parapharyngeal space, it should have fat circumferentially surrounding it. So here on the axial and coronal T1 weighted images, we see this T1 hyperintense fat all around this lesion. It's well circumscribed and it's relatively T2 bright. So this is a benign mixed tumor arising from one of those minor salivary glands in the parapharyngeal space. Next, we're going to move on to the pharyngeal mucosal space, which is the most medially located space in the suprahyoid neck. This space also extends cranially to the skull base and importantly abuts foramen lacerum, which we'll look at a little bit more closely. Inferiorly, it's going to be continuous with the larynx. Laterally, we have our parapharyngeal space. Anteriorly, we have the nasal cavity, and then more inferiorly, the oral cavity. And posteriorly, we have this thin retropharyngeal space. So the pharyngeal mucosal space has this large sheet of mucosa, so this is going to be an important site for squamous cell carcinoma that arises from that pharyngeal mucosa. We also have a lot of lymphatic tissue in the adenoids and the lingual and palatine tonsils, so they can be affected by hypertrophy, infection, or lymphoma. We also have numerous minor salivary glands throughout throughout the mucosa and submucosal spaces. And then we have the pharyngeal constrictor muscles, which form some of the boundaries of that mucosal space. So here's another look at foramen lacerum. So here on either side of this sphenoid body, we have this osseous defect, and on this soft tissue images, you can see that it sort of forms the floor of the junction of the petrous and cavernous internal carotid artery. This is an important route for spread of malignancy or even infection from the pharyngeal mucosal space into the intracranial compartment. So that's an important structure to remember. So this is a patient where you see a centrally low density peripherally rim enhancing fluid collection along the lateral oropharyngeal wall next to some reactive hyper enhancing tonsillar tissue. So this is a classic appearance for a peritonsillar abscess. This is a different patient, and we see this asymmetric abnormal soft tissue filling this lateral nasopharyngeal recess, and this is a patient with nasopharyngeal carcinoma. So this is a case where you're going to want to make sure and look at the skull base interface and make sure you don't have any intracranial extension of disease. So the next space we're going to talk about is the masticator space, and you want to remember that this has a suprazygomatic and an infrazygomatic component. So this area in purple is mostly demonstrating the infrazygomatic component, also known as the infratemporal fossa. So the masticator space also has a broad abutment with the skull base, and importantly abuts foramen ovale, which transmits V3, or the mandibular nerve, as well as foramen spinosum, which is going to transmit the middle meningeal artery. Inferiorly, this deep cervical fascia is going to extend over the inferior border of the mandible. Anteriorly, we have this fat-filled buccal space, and then posteriorly, we have our parapharyngeal and parotid space. So in the masticator space, we have our four muscles of mastication. So those are going to be the medial and lateral pterygoid muscles. So the lateral pterygoid is the more superior of the muscle, and the medial pterygoid is the more inferior. And both of those muscles are going to be located medial to the mandibular ramus. The masseter muscle is located lateral to the mandibular ramus. And then here we see a portion of that temporalis muscle, and you can see that suprazygomatic extension of the masticator space. We talked about V3 and its branches, so here we see that small defect in the skull base, so this is going to be foramen ovale, and we know V3 is going to come right from the intracranial compartment through there into the masticator space. Then we also have the posterior body and ramus of the mandible, as well as the temporomandibular joint. So on the axial images, here we have that more superior lateral pterygoid muscle attaching to the mandibular condyle. We see the temporalis muscle slightly anteriorly, and then when we go down to the level of the oropharynx, we see the medial pterygoid muscle medial to the mandibular ramus, and then the masseter muscle lateral to the ramus. And then on the coronal image, you can nicely see that continuation between the infratemporal fossa and this suprazygomatic masticator space along this temporalis muscle. And our MR, we can beautifully see again that mandibular nerve coming through foramen ovale and entering the masticator space. On our axial image, here's that proximal main trunk right next to that lateral pterygoid muscle. So this is a patient who has this large osteosarcoma rising from the mandibular ramus and condyle, and you can see it's sort of filling up that masticator space. We have some displacement of the pterygoid muscles. It looks like it's probably replaced the lateral pterygoid muscle, and we have infiltration or edema of this masseter muscle and the temporalis muscle as well. Probably the most common pathology that's going to involve the masticator space is an odontogenic abscess. So here on our bone windows, we see some irregularity and a little defect along this left maxillary extraction socket, molar extraction socket. And on the soft tissue windows, we see this small rim enhancing abscess, as well as marked edema and enlargement of the muscles of mastication, including the masseter here. So next we're going to move on to the parotid space. So superiorly, the parotid space is going to abut the external auditory canal and the mastoid tip, and importantly it also abuts the stylomastoid foramen, which is going to transmit the seventh cranial nerve. Inferiorly, the parotid tail is going to extend towards the submandibular space. Medially we have our parapharyngeal space and the carotid space. Anteriorly, again, we have that masticator space, and posteriorly we see this perivertebral space. So the parotid space, or the parotid gland, can be divided into superficial and deep lobes based on the plane of the seventh cranial nerve. So we can't always see the seventh cranial nerve, so we estimate its location by drawing a line from the region of the stylomastoid foramen to the lateral margin of the retromandibular vein. So these two vessels, the larger of which is going to be the retromandibular vein, and the smaller one adjacent to it is the external carotid artery. This inferior projection of the parotid gland is also referred to as the parotid tail. And then the parotid duct is going to emerge from the anterior aspect of the gland, course over the masseter muscle, and then pierce the buccinator muscle to drain along the buccal mucosa. On the next image, we have that really important skull-base interface at the stylomastoid foramen. So here we have the styloid process, and posteriorly we have the mastoid tip and a little space between the two, which is going to be the stylomastoid foramen. And on every CT and MR, you want to make sure you see a nice fat-filled space there, so you know you don't have any extension of malignancy going up the facial nerve. We also sometimes refer to the stylomandibular tunnel, which is this little gap between the posterior aspect of the mandibular ramus and the mastoid tip. So here we have an aggressive-looking parotid malignancy. You see this ill-defined low signal on the T1 weighted sequence involving the superficial and deep lobes of the parotid gland and extending to the skin surface. The post-contrast image shows similar findings, where you have this enhancing mass extending through this stylomandibular tunnel involving both the superficial and deep lobes of the parotid gland. So this is a more benign, sort of well-circumscribed appearing lesion. And we talked previously about those parapharyngeal space lesions where you should want to see a nice plane of fat all the way around it. So in this case, we never see a clear plane of separation between the deep lobe of the parotid gland. So this turned out to be a benign mixed tumor, also a salivary gland neoplasm arising from the deep lobe of the parotid gland. And you can see our parapharyngeal fat stripe sort of medially displaced. And I also want to point out that you see the internal carotid artery posterior to the lesion. So the visceral space is going to be the continuation of our pharyngeal mucosal space into the infrahyoid neck. Inferiorly, it's going to extend to the mediastinum. Posteriorly, we have the retropharyngeal space, and laterally, we see the carotid space. So the visceral space is going to contain the hypopharynx and larynx, and the inferior continuation of those two, which is the trachea anteriorly and the esophagus posteriorly. We also have the thyroid and parathyroid glands, and then you want to remember that those recurrent laryngeal nerves are going to travel in this tracheoesophageal groove as they course from the thoracic inlet back up towards the larynx. And then the visceral space is also going to contain pre- and paratracheal lymph nodes. So here again is our CT image of the visceral space. We see our trachea anteriorly, our esophagus posteriorly. This is going to be our tracheoesophageal groove where those recurrent laryngeal nerves are going to run, and then we see the two lobes of the thyroid gland. So this is a patient with a thyroid goiter, and you see a normal appearing right thyroid lobe, and on the left we have an enlarged heterogeneous left thyroid lobe that's displacing the trachea and the esophagus towards the right, and on the coronal image we see that there's some mild tracheal narrowing as well. So now we're going to move on to the spaces that continue in the suprahyoid neck as well as the infrahyoid neck. So the carotid space goes from the skull base, and it's going to butt the carotid canal, the jugular foramen, as well as the hypoglossal canal, and extend inferiorly to the aortic arch. Anteriorly, we have that fat-filled parapharyngeal space. Posteriorly, we have the perivertebral space. This is an important osseous landmark. So just lateral to the carotid space, we have our styloid process, and further laterally, we have the parotid space, and then medial to the carotid space, we're going to have the retropharyngeal space. So in the suprahyoid carotid space, in addition to the carotid artery and the internal jugular vein, we're going to have the 9th through 12th cranial nerves. The sympathetic trunk technically isn't in the fascial lining of the carotid space, but we know that it's located immediately medial to the carotid artery. And then remember that those glomus bodies are found along the jugular bulb, the vagus nerve, and the carotid bodies. So here's our smaller, more medial internal carotid artery, the more lateral and larger internal jugular vein, and then our anatomic landmark of the styloid process. So in the infrahyoid carotid space, most of our cranial nerves that were found in the suprahyoid compartment are going to have exited to their respective locations, with the exception of the vagus nerve. So the vagus nerve is going to continue down in the carotid space, and on the right, the vagus nerve is going to loop around the subclavian artery, and on the left, around the aortic arch before the recurrent laryngeal nerves course superiorly again in that tracheoesophageal groove. So in the infrahyoid neck here, we see the smaller common carotid artery, and then right next to it, the internal jugular vein, and same appearance. Here we are at the level of the hyoid bone. So again, the boundaries medially, we're going to have that visceral space, or the pharyngeal mucosal space, as well as the retropharyngeal space. Laterally, we have the posterior cervical space, which we'll talk about in a minute. Anteriorly, we see the sternocleidomastoid muscle, and then posteriorly, we have the perivertebral space. So given that there are so many cranial nerves in the suprahyoid carotid space, one of our main differential considerations is going to be a nerve sheath tumor. So here we see a well-circumscribed T2 hyperintense lesion, and what you want to notice is that it's splaying the internal carotid artery superiorly and the internal jugular vein laterally. And remember, as opposed to that deep parotid space lesion, which was displacing these posteriorly, we have elevation of the internal carotid artery. So this is a classic appearance for a vagal schwannoma. This is a different patient with a glomus jugulare. So at the level of the jugular foramen, we have this expansile, avidly enhancing lesion with some osseous erosion and irregularity around it. And as we go slightly inferiorly, we see it's uplifting this internal carotid artery, and it's located right in the location where we expect our internal jugular vein to be. So this again is a classic appearance for a glomus jugulare. This is a similar appearing lesion. It's avidly enhancing, but this time we have separation or splaying of the external carotid artery and the internal carotid artery, and this lesion is located at the carotid bulb. So this is another characteristic appearance and location for a carotid body paraganglioma. Okay, so moving on to the retropharyngeal space. So our retropharyngeal space is going to be a thin sort of potential space between these two fascial compartments. It's located behind the pharyngeal mucosal space, and in front of our prevertebral muscles. Laterally, we have the parapharyngeal and carotid space. Superiorly, the retropharyngeal space is going to extend from the clivus and inferiorly to about T3, but you want to remember, very importantly, that the retropharyngeal space is continuous with another space called the danger space. We can't separate these two spaces on imaging, but we know they're right next to each other and that they communicate with each other. So anytime you have an infectious process or any process involving the retropharyngeal space, you want to remember that the danger space extends inferiorly to the mediastinum, so you want to extend your search down into the thorax to see if you have any spread of infection beyond the neck. Another important fact to remember is that in the suprahyoid retropharyngeal space, we have lymph nodes, which are an important route of lymphatic spread for a lot of the upper aerodigestive tract malignancies. Below the hyoid bone, there are no lymph nodes in the retropharyngeal space. So this is a normal example. So here we see the posterior pharyngeal wall, and in between it this thin fat stripe of our retropharyngeal space, and that's located in front of these two prevertebral muscles, which are right in front of the vertebral body. So in this patient, we have a suppurative retropharyngeal lymph node. It's low density and enlarged. Notice it's just medial to our carotid space and carotid vessels, and as we look slightly more inferiorly, we see this low density fluid collection behind the posterior pharyngeal wall and in front of our two paired prevertebral muscles. So that's that retropharyngeal effusion related to this suppurative lymph node. Again, this is a sagittal image, again showing a retropharyngeal effusion where compared to this normal patient, we see thickening of these prevertebral soft tissues and this low density fluid collection lifting up the posterior pharyngeal wall and in front of our prevertebral muscles. So again, this case is just highlighting the importance of remembering that danger space and that continuity with the mediastinum. So here's a patient with a retropharyngeal abscess, and we can see that it extends inferiorly into the posterior mediastinum. Okay, so moving on to our perivertebral space, we can divide the perivertebral space into two components, a prevertebral component, which is located anterior to the vertebral body, and then a paraspinal component, which sort of surrounds the transverse and spinous processes. So our perivertebral space is also going to extend from the skull base to the thorax. Anteriorly, we have the retropharyngeal space as well as the carotid space, and posteriorly, we have the posterior cervical space, which we'll get to in a minute. So in the perivertebral space, we have the pre- and paraspinal muscles. More inferiorly, we'll have our three scalene muscles. We have the vertebral body and its posterior elements, as well as the spinal cord and the exiting nerve roots, including those roots of the brachial plexus. You also want to remember that the phrenic nerve is going to travel along that anterior margin of the anterior scalene muscle, and then we have the vertebral arteries traveling in the perivertebral space as well. So the prevertebral muscles we touched on a little bit before, but those are going to be those two paired muscles right in front of the vertebral body. So here we are at the level of the dens, and then more inferiorly again, we see these two paired prevertebral muscles. The paraspinal muscles are going to be these lateral and posterior muscles, and more inferiorly here we see the scalene muscles adjacent to the transverse process. So this is a patient with a paraspinal abscess. On the STIR sequence, we see a lot of edema and inflammation involving in this paraspinal compartment. And on the post-contrast T1 images, we see these small rim-enhancing fluid collections. And you want to remember that this infection can spread into the intraspinal or epidural space. And here you can kind of make out that there are some thickening and inflammatory changes involving that epidural fat. Okay, so I think this is the last space. So this is another space that's predominantly fat-filled. So the posterior cervical space is going to be located lateral to our perivertebral compartment, lateral or superficial to, and deep to these larger sternocleidomastoid and trapezius muscles. Again, mainly we have fat in the posterior cervical space, but importantly, we have several lymph node chains, as well as the 11th cranial nerve and the divisions and cords of the brachial plexus. So on the sagittal CT image, you can see this fat-filled space with a few lymph nodes inside, posterior to the sternocleidomastoid muscle and anterior to the trapezius muscle. On our axial images, again, we have our sternocleidomastoid muscle superficially and the perivertebral muscles deep to the posterior cervical space, and same relationship here. Our perivertebral compartment, posterior cervical space, and then more superficially the sternocleidomastoid muscle and the trapezius muscle. And here we see a patient with some prominent sort of enlarged posterior triangle lymph nodes in that fat-filled posterior cervical space. So I think we covered all of these compartments. I hope you enjoyed the lecture. This is a patient that had a pharyngeal perforation. You can see how that air, that subcutaneous emphysema sort of nicely outlines some of the spaces that we talked about. All right, thank you so much.